Hi, I hope you guys are doing well. Welcome, welcome, welcome. I'm just setting up my live for my study session. I'm trying to get onto TikTok as well. All right. So just bear with me for 2 seconds. I think I'm a little bit too close. Kayla, how are you doing? Mary Mush. Let's see. I'm just checking to see if I'm live on YT. Yeah, I'm live there. Oh, forgot this part. Share up the live. All right, let's share up the live. Thank you guys for liking up the live so far. I appreciate that. How are you guys doing though? I was trying to rush and see if I could come on a little bit earlier, but it wasn't working out in my favor at all again. The Jamaican nurse, huh? We call them late bug. Yeah. I was trying to rush again and it wasn't working out. But I'm here on time. I'm here on time. Angela, how are you doing? Hi on YT. I'm gonna try to turn on the other light here. Even though I'm not gonna be the focus of the night. But let me just turn it on. Okay. You see any spring chicken yet? You see any more spring chicken? I'm waiting. I'm waiting to see the, well, let me say the frog. That delicacy. I'm waiting. I don't see you post anything yet. You don't see any yet? No, sir. Cuckoos. Hello, hello, hello. Welcome, welcome. Hi, guys. Welcome to the live stream. Tonight we're gonna go through some more. I think we have like OB questions, maternity questions, and some additional, questions. So we'll go through those and we'll have fun again. The last night, on Tuesday night was fun. Just like all the other nights when we were studying. So if you missed the live, you have to go onto YT, subscribe to the page over there. It's ThinkNursing. It's the same as the handle here. And you'll get the full length of the live streams posted over there. All right, so just in case you're hopping on for the first time and you want to see the live streams that we've done, they're all posted on YT on YouTube at ThinkNursing, one word. You can go through, play them at your own pace. Oops, it's me, it's her. My day was good. It was good. I had my meeting with my new company. And it went well. It was a little bit longer than I expected, but yeah, it was good. Still in the process of getting, credential for all the companies, but it's a start. it kind of soak in that me have to go work for basically 2 months without pay. Oh Lord, but you know, I am open to it. I am open to it. When it show up on the screen, I'm like, oh Lord. Well, basically 1 month. I'm gonna have to work 1 month and then no pay. So I work 1 whole month and then work the other month and get pay at the end of that month. So basically 2 months I work without pay. Okay, nice to know. Keep excelling, queen. Yes, but when the pay finally reach and double, it's not double there. It's one pay in the back, just like in Jamaica, 1 pay in the back. So that's why I'm okay with it. But for me, it feels like you're working you're gonna be off. You're gonna be working 2 months without pay. Sarah, hola, 4 eyes. Welcome, welcome, welcome. All right, guys. Yes, let's tap up the live. Let's tap up the live. Universe, we're gonna say universe, okay? Universe, hello, how are you doing? Let's tap up the live, share up the live. If you haven't subscribed, as it, subscribe to my page, turn that notification bell on so you can come back to the page whenever, you know, I post a new video. My sister did the same thing and she got double, but I guess it depends on when the pay cycle. Yes, exactly. It will go fast, definitely. I am doing good. I'm doing good. All right, thank you for doing that, guys. Thank you for doing that. All right, so as I said, we're gonna be doing some questions tonight. We'll go through some easy question as usual. I'll pick your brain and we will answer the questions. We'll try to save the patients that we have on the board. Deal? Sarah, no, I prefer call you Sarah. How are you doing? Frozen, I'm doing good. I'm doing good. Thank you, guys. And remember, if you have any friends, nurses, you know, send them over to my page. Let them come over and be a part of the family here. All right? And if anybody know of any technician, any ultrasound technician as well, someone in the chat here, she is planning on doing the course. She doesn't know anybody and she wants some support. So feel free to go ahead and inbox me so she can actually get some information from that person. So she's interested in the ultrasound technician course. All right, let me turn this. So, oh, it's supposed to be the beginning. Where is my, let me turn this around. Flip, let's see. That is supposed to be the beginning. The end, but the beginning of. Let me try to get my, where is it? It's always lost. But okay. Is it readable, guys? Let's tap up the screen. Let's tap up the screen. Is it readable for you guys? Carousel, welcome. Thank you for sharing, Nicole. Okay, nice. Okay, so this is the end of the last presentation or the video we did or questions we did the last time. So if you want to see the questions, it's posted on my YouTube page, so you can feel free to go over there and get that live stream or that video. So the memory triggers, we had boggy uterus. If you have a patient with boggy uterus, you go ahead and massage and stop the and start your oxytocin. All right, severe preeclampsia. Usually you give your magnesium first. If you have a patient with absent reflexes on mag, you stop the infusion. Late D cells usually is a placenta problem, and bleeding postpartum is an emergency. So basically that was like the last few questions. All right, so let's move on to the beginning of tonight's question. And it goes like this. The nurse is preparing or prioritizing care for 4 patients. Oh, this one is similar to the question we had the last time. The nurse is prioritizing care for 4 clients. Which patient should the nurse see first? A, client with glucose of 240, client reporting pain 7 out of 10, post-op client with blood pressure 84 out of over 46, and client with COPD and oxygen saturation of 90%. So you have these 4 patients, you're prioritizing care. Who will you see first? Is it the client whose glucose is 240? Is the patient reporting pain that has 7 out of 10? A post-op that is having a blood pressure 84 over 46, or the client who has a oxygen saturation of 90% but is COPD? And we say CCC, nice. Okay, yeah. So we say the post-op patient that has a blood pressure 84 over 46, and we say because of, what's the rationale with this one? Post-op, blood pressure is low, we're thinking hemorrhage. We're thinking because of the possible hemorrhage shock. All right, so severe hypotension, post-op such as possible hemorrhagic or shock, a life-threatening circulation issue. Okay, so even though you have your COPD, and we know that, yes, it might be a breathing problem, this is normal or acceptable for your COPD patient. 88 to 92% is okay for your COPDs, so 90% is good. The client reporting pain, we definitely want to address, but that's not like priority. Your glucose here, it's elevated, but not priority. So you definitely want to address your circulatory problem, okay? And then from there. Which nursing action requires intervention by the nurse? A, elevating the head of the bed during feeding, tube feeding. B, injecting insulin subcutaneously at 90-degree angle. C, verifying 2 patient identifiers before medication administration. D, massaging the site after administering heparin. Which nursing action requires intervention by the nurse? A, elevating the head of the bed during the tube feeding. B, injecting insulin subcutaneously at 90-degree. C, verifying two patient identifiers before medication administration. Or D, massaging the site after administering heparin. D. Why do we say D? Remember, you give an injection, it hurts. So why not just go ahead and massage the patient, you know? Why not just go ahead and rub it in for the patient? Risk of bleeding. Okay. What kind of medication is heparin? What kind of medication is heparin? So Kayla says massaging the site can cause discoloration under the skin. Okay. It's an anticoagulant. Good. Yes. So because of that, it's an anticoagulant. So because of that, you have the high risk for bleeding. So you don't want to go ahead and massage. And just remember, you puncture the skin. All right. So then there is always going to be that leakage. So you're going to have that bleeding. Okay. Verifying 2 patient identifiers before medication administration. That is very important. Give me 2 different, or give me a few patient identifiers that we can use. What are some patient identifiers? Give me some patient identifiers that we can use. Date of birth, okay, good. Photos, okay. Check-in ID band, medical record number, good. Name, yes, patient band. What about the room number? Age. What about the room number? No? Okay. Yes, so room number is not one of them. Good. Okay. Because I know sometimes we always say, oh, patient in room 10. You know? We always all of us are guilty of that. Patient in room 10, Elevating the head of the bed during tube feeding is good. Injecting sites subcutaneously at 90-degree angle. Dementia patient could walk in that room. Exactly. All right. So which nursing action requires intervention by the nurse? We say D, massaging the site after administering heparin. So the heparin increases the bleeding risk. So massaging the site can cause the hematoma formation. So you want to make sure you avoid doing that. Good. So all of those are different identifiers and things that we can do. Okay. And what's the antidote for your heparin? If you have a patient that is on heparin and they're bleeding too much, what is your antidote? What can you give to reverse that? You have a patient that is bleeding too much. What can you give to reverse that medication? Protamine sulfate. Okay, good. Vitamin K is for which, what do we use vitamin K for? What do we use vitamin K for? Warfarin. Okay, good. Yes, Kayla. Nice. Okay, good. And then seeing that we're still on these, you have this patient and you have the patient on warfarin. What blood tests will you be checking to see their levels? What tests will you be checking? So you have this patient that is on warfarin. What levels will you be checking? You're checking your INR. You're checking your INR. And what you check for your heparin. If you have your patient on the heparin, you check your PTT. Good. Yes. So for your heparin, you check your PTT, your INR, your warfarin. You're good, Nick. All right, let's move on to the next question. Which assessment finding is the earliest? Remember, look at the keywords. The earliest indicator of increased intracranial pressure. Which assessment finding is the earliest indicator of increased intracranial pressure? A, fixed and dilated pupils. B, restlessness and confusion. C, bradycardia. D, widened pulse pressure. Yes, I am doing good. Daily Bible verses. Thank you. So which assessment finding is the earliest? So let's see, B. Pink Lemonade says D. Okay. B. Okay, so Pink Lemonade and Temitope says D. All right, so B. So a lot of persons says restlessness and confusion. Fixed and dilated pupils, restlessness and confusion, bradycardia, widened pulse pressure. Biojisek, welcome, says BB. So restlessness and confusion. So mental status changes are early. Okay, those are early signs. And then the others are late. So your fixed and dilated pupils are late. Your widened pulse pressure is late. Your bradycardia is late. Okay. So you have this patient that has increased intracranial pressure. How would you position widened pulse pressure R along with Cushing's triad so late? Yes, Rijon Cortez. Good. So you have this patient with increased intracranial pressure. How would you go about with managing this patient? What are some non-pharmacological, management for this patient? What can you go into? Head of the bed, 30 degrees. Good. Okay, nice. No bending over, positioning. Yes. Raise head of the bed to help with drainage. Good. I wouldn't lie them down. Yes, because all of those is going to help with increasing their pressure there. So positioning is very good for them. Calm environment, low stimuli, seizure precautions. Good. Okay, so you have this patient and no coughing, dim lights. Good. So you have this patient and the doctor is saying, okay, then we're going to be starting some fluids on this patient. We're not fluids. We're going to start some diuretics on this patient. What diuretic are you anticipating for this patient? So the doctor says we're going to start some diuretic because we want to try to get this pressure down. What? Mannitol. Okay, nice. That's what I was looking for. Osmotic diuretic. Mannitol. Yes, Rijon Cortex. So osmotic diuretic. Mannitol. Good. Okay. All right, nice. So we have, as I said, we have here restlessness and confusion, hypertonic saline. Okay, nice. Dorian, welcome, welcome, welcome. Nice having you. So we say here the earliest. So we're looking at earliest indicator of intracranial hypertension, increased intracranial pressure is your mental status changes. So your restlessness and confusion. All the others are late. So if you have a patient with fixed and dilated pupil, that is late. With the bradycardia, the widened pulse pressure, that's late. Okay. All right, let's move on to this question here. A client suddenly develops facial drooping and slurred speech. What comes to your mind here? What condition are you thinking about here? Thank you, Dorian. Happy New Year to you guys too. So you have a patient that suddenly develops facial drooping and slurred speech. What comes to your mind? What are you thinking? Okay, activate your stroke. Okay, nice. Stroke, Nick. Nice, yes. So what should the nurse do first? A, place the client in a supine position. B, administer oxygen. C, check blood glucose. D, activate stroke alert, notify the provider. So everybody says D, 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 activate stroke alert. Good. Let me see if anybody else is different here. Okay, so user 771 says B. We'll put on some oxygen. Okay. What are some other signs and symptoms of stroke? So we have facial drooping, slurred speech. What are some other signs and symptoms of stroke? Aphasia, weakness. I see left-sided, right-sided, unilateral limb weakness. Yes. Be fast. Good. Okay. So you go ahead and activate your stroke alert, and then from there. So let's go on. So why do we check the glucose for our stroke patient? Or is it important for us to check the glucose for our stroke patients? Is it important for you to check your glucose for your stroke patient? Or we just send them over to CT scan and just get it out of the way? Is it important for us to get the... Is it important for us to get the glucose for our stroke patients? So Nicole says yes. I don't know. Mike says no. Why not, Mike? It's not important. It's important. It's very, very important. Oh, okay. We'll go to that shortly. User 771. And I see Janine Amalie asking something. Oh, I think I missed the... Okay. She was asking about the B-fast. Sorry. So it's very important for us to go ahead and do the blood glucose for your patients, because if the patient is hypoglycemic, they can also present with similar symptoms like your stroke. So hypoglycemia, you know, you can mask, your stroke can actually mask like, you know, your hypoglycemia or vice versa. So definitely get your glucose, and then from there, once you get that out of the way, you rule it out, then you can proceed with everything else. But you want to make sure that that patient is not hyperglycemic, and then you treat your stroke. Administering oxygen is pretty good. If they're hypoxic, how do you know when to apply airway breathing circulation? So it depends on what is going on with the patient. So even though, yes, you know, you're using the airway breathing circulation method, you're still gonna look and identify, is this an airway problem? If there is, then you address the airway. If it's a breathing, you address it. If it's a circulatory, then you address the circulatory. But not because you see the answer, administer oxygen, you just jump and go and use it, you know. It has to match the scenario there. So D is the one you will definitely go ahead and activate because of the stroke-like symptoms. Then you will get your glucose. All right, that is time sensitive. So based on what is happening, it's a neurological problem. So you definitely airway breathing circulations, and then you look at the mental status and address it. So sudden neurological deficits indicate acute stroke. Time sensitive intervention is critical. So is there an airway problem? No. Breathing problem? No. Circulatory problem? No. D, disability. You definitely go ahead. There's slurred speech, facial drooping. Definitely address that, and then from there. I saw C, check glucose. Oh, okay. Okay. So just make sure you go through and look and see if there is one of those problems, and then from there. But with stroke patients, you aren't getting oxygen to the brain. So go ahead and check your oxygen saturation. Go ahead and check your oxygen saturation and see what the oxygen saturation is. Everything is time sensitive for the patient. Everything is time sensitive for the patient. So check your oxygen saturation, but the answer is D. Check your oxygen saturation and get that going. But the most important, the first thing you want to do is activate your stroke alert. Get everybody, the CT scan empty so you can get your patient over there. Can we first check the blood glucose? You're definitely going to get your blood glucose, but you want to go ahead and activate your stroke. Go ahead and activate your code stroke. In the meantime, you're getting your glucose. Oxygen is usually normal. So if the oxygen is normal, you don't need to be putting on oxygen on the patient. I think you need a SAT before choosing that answer. Yeah. So as I say, if the scenario that they present in the question doesn't address or, you know, suggest that there is something is happening with the oxygen, then I wouldn't go ahead with it. You check for a stroke. Yes, I'm man. Danny. No, I'm Stacy. Okay. But you must, it's very important for you to get your glucose though, okay? Very, very important, because the last thing you want is by the time you get the patient over there, you check, you realize that this glucose is 10. All right, don't try to change the question or work. So yeah, don't try to change the question, work with the information that they give. Yeah, whatever is in the scenario, just work with it and that's it. All right, let's look at another question here. Which finding most strongly indicates hypoglycemia? A, fruity breath odor. B, excessive thirst. C, diaphoresis. D, cosmal respiration. Which finding most strongly indicates hypoglycemia? Nicole says A, fruity breath odor. So C. Kim says B, excessive thirst. So strongly indicates hypoglycemia. A lot of times when you have, Nicole says she changed her answer to C. Is it peer pressure, Nicole, or you're just changing it to C because cool and clammy? Brenne Lou, yes, cool and clammy, C. No, not peer pressure, good, okay. So a lot of times when your patients are hypoglycemic, you know, they're always like cool and clammy. So they're always diaphoretic, so that's a given. Signs and symptoms. SNS activation. Nikki, welcome, welcome. They always need candy. Hot and dry when their sugar is high. Excessive thirst, fruity breath. Which of the diabetes are we thinking about here? What is happening here with this patient? If a patient is having fruity breath, what is happening here? Are you thinking that patient is hypoglycemic? DKA, nice. Okay. And what if they're having cosmal respirations? So what if the patient is having cosmal respirations? DKA as well? Yes, good. So which finding strongly suggests the patient is hypoglycemic? Diaphoresis. Hypoglycemia causes sympathetic nervous system stimulation. So you have sweating, shakiness, anxiety. So C is the answer for this one. Okay. So you have your patient who is hypoglycemic in front of you. Patient is talking. How would you go about with treating this patient? Thank you, Lois. You have a patient that is hypoglycemic, but the patient is talking. Patient is responsive. How would you go about with treating your patient? Give candy. First, get the glucose. Give them insulin. Stunner girl. Stunner. Stunner is a joker. Right, Stunner? Stunner want to wrap the body. I can't manage. Stunner want more work to do as a nurse. Orange juice, 15 carbs, yes. Truly yours, 15 carbs. So remember, this patient is hypoglycemic, okay? So patient is hypoglycemic, so no insulin for this patient. So you want to give this patient a lot of sugar, okay? No insulin. So 15 sugar or 15 carbs. Then you recheck. If it's still low, you go ahead and give some more carbs. orange juice, anything like that. Anything that has a lot of carb. Candy. Yeah, man, I think Stuna girl joking. Okay, but what if this patient is hypoglycemic and won't the GMR decide the mode? So even if, so for example, the patient is hypoglycemic and it's 40 and the patient is talking, they're able to swallow, you can always go ahead and give them the something to eat. If they are hypoglycemic 40 and they are not responsive, then definitely you want to go ahead and do what? You don't want to change. You won't give them anything orally to eat because of the risk for aspiration. So you'll go ahead and do like a glucagon and you'll get your IV dextrose given. No insulin. Andy, MD, no insulin. We're not doing any insulin. It's hypoglycemic. Yes, take your hand off of your forehead. No insulin. So you're gonna give them some 50% dextrose. Oh, you meant IV. Okay. Yes. Give them some dextrose, IV dextrose, and then you give them some glucagon. And then repeat your glucose. Nice. All right, so the answer, as we say, it's C. Hypoglycemia causes sympathetic nervous system activation. So sweating, shakiness, anxiety expected. So go ahead and treat your hypoglycemia. Which patient has the highest risk for aspiration? A, client with pneumonia. B, client with asthma. C, client with recent cerebrovascular accident. D, client with COPD. So which client has the highest risk for aspiration? The client with a recent cerebrovascular accident. C, unable to protect airway. Dysphagia, diminished gag reflex. Christopher, C, nice. Okay, the stroke patients often have impaired swallowing and gag reflex. Okay, good. So you have this patient here in front of you. It's a stroke patient. All right. And what are you anticipating? So you need to find out whether or not this patient is able to swallow. What test will you be doing as a nurse? What test will you be doing for this patient? What test will you be doing? So you have this patient in front of you. Cookie swallow. Swallow study. Swallow test. Tongue depressor. Gag reflex. Checking their peristalsis. Yeah, swallow eval. Yes. You do your bedside swallow eval. Like take a sip of water. Yes. So you deal with this bedside swallow eval, and then from there, once they pass or fail, then they can go ahead. Once they pass, you can go ahead and feed them. If they fail, then you have the, what do they call them again? The speech therapist. Who Dr. Ben Carson's GCS less than 9 or swallow test positive. The speech therapist, yeah, come in and see them. Thickened liquids, not thin liquids. Thickened, yes, thickened liquids. Lewis 62. Okay. Let's move on to this one. A patient in ventricular tachycardia with a pulse and hypotension. Is this patient stable or unstable? A patient in ventricular tachycardia with a pulse and hypotension. Is that a stable patient or unstable patient? Unstable. Okay. Why do you say it's unstable? Why you say it's unstable? Let me see. Why you think this patient is unstable? Why is this patient unstable? Beta can deteriorate. Hypertension with tachy means they're trying to compensate. Okay, yes. But even with the pulse and the hypertension, if you never had the hypertension and you just see a patient with VTAC, and you just see a patient with VTAC, would you say that patient is stable? Would I run same way? When I see a patient with VTAC, when I see a patient with VTAC, not stable. Not stable. All right, so a patient is in VTAC, ventricular tachycardia with a pulse and unstable. What is the priority action? A, administer amiodarone. B, begin CPR. C, deliver unsynchronized shock. Or D, perform synchronized cardioversion. It's a ACLS emergency. Bambi girl, yes. You can't administer without an order, right? No, you can't administer without an order in the not TikTok world. In NCLEX world, all the orders are there. In the real world, when you have these kind of emergencies, you'll go with your ACLS guidelines. You'll have your verbal orders, your providers there as well. So you don't stand around waiting for the doctor to put the orders in the system for you to go ahead and deliver your shocks. All right, so you go ahead and do what you're supposed to do based on your ACLS. As I said, the providers are there, so you go according to the guidelines. So your unstable VTAC with a pulse requires synchronized cardioversion. So the priority action is that. So the priority action. So priority. Okay, so as we said, this is a unstable patient. The patient is unstable. The patient has hypotension. The patient is in VTAC. The priority is to get this corrected. This VTAC corrected, this hypotension corrected. So you want to go ahead and do your synchronized cardioversion to help with that. Uh-oh, I didn't. Get the crash cart and all. You can give amiodarone if only the blood pressure was normal. Yes, Rose. Yes, in NCLEX, you always have your orders. So don't think of it that you're standing there waiting for orders. You're not waiting for any orders. The orders are there. So it's a perfect world, perfect patient that is just sick. So you go ahead and you get your crash cart and, you take care of your patient. All right. Which laboratory value requires immediate intervention? A, sodium of 147 milliequivalent. B, potassium of 3. C, calcium of 9.4. Or D, magnesium of 2.0. So which value requires immediate intervention? Sodium, potassium, calcium, or magnesium there. Okay, so B. What's the normal sodium value? So the potassium is critical due to dysrhythmias. Okay, what's the normal potassium value? Okay, so 3.5 to 5. And then the sodium was 135 to 145. Good. And calcium? No, the 9.5 to 10.5. So just know the range that they're using for your NCLEX. For, yeah, I know the 9.5 to 10.5. And then what's the range for magnesium? What's the range for the normal range for magnesium? So 1.5, 2.5, 1.5, 2.5, or some 1.7, 2.2, something like that. So 1.5, 2.5, that's the one. I know. So they have different numbers. Okay, so the laboratory finding that requires immediate intervention is going to be your potassium 3.0 because of hypokalemia, which can cause fatal cardiac dysrhythmias. Okay, so hypokalemia, that's the one that is the problem there. So you want to make sure you get your patient on the cardiac monitor, and then from there we will go ahead and replace your potassium. Okay. Let's go down to this one. Which assessment finding is expected in a client with Addison's disease? Which assessment finding is expected in a client with Addison's disease? Hypokalemia is a major trigger for VTAC. Also, it's related to the question before. Bambi girl, yes. Which assessment finding is expected in a client with Addison's disease? A, hypertension, B, hyperglycemia, C, hypokalemia, D, hypotension. So I see D, A, hypotension, okay. I see your answers there. All right, before I show the answer, what gland is being affected in Addison's disease? What gland is being affected in Addison's disease? Okay, so adrenal glands is being affected in Addison's disease. Yes, I was asking which gland is being affected in Addison's disease. And what two hormones are being affected? The sweat. Nicole. Which two hormones are being affected? Their body fat is depleted. Cortisol and aldosterone. Okay. So cortisol. Okay. So which assessment findings is expected in a client with Addison's disease? A, hypertension, B, hyperglycemia, C, hypokalemia, D, hypotension. Addison's disease causes low cortisol and aldosterone, leading to hypotension and electrolyte imbalances. So your hypotension. So once you understand, you know, the pathophysiology behind Addison's disease, then you'll be able to choose your answer based on that. Okay, so adrenal gland insufficiency. User, a bunch of R's. Welcome, welcome, welcome. Patients needs yes, oops, it's me. So this patient is gonna need IV hydrocortisone therapy there. Christopher, yes, cortisone. Nice. Thank you for tuning in. I should have been a doctor, but I was too white. Okay, typo. Okay, no problem. That's why I'm not about to read it. But welcome to the class though. Okay, let's move on to this question here. Which finding is the best indicator of fluid volume excess? A, crackles on the lung or on lung auscultation. B, dependent edema. C, weight gain of 2 kilograms in 24 hours. D, elevated blood pressure. So which finding is the best indicator of fluid volume excess? A, crackles on lung auscultation. B, dependent edema. C, weight gain of 2 kilograms in 24 hours. Or D, elevated blood pressure. Let's see AA, then we see C's, weight gain of 2 kilograms in 24 hours. So the best indicator of fluid volume excess. So the best indicator. So if you want to find out if this patient, are you gonna be, B is the only option that is a diabetic. Is option that is diabetic. So is it the crackles on the lungs, dependent edema, weight gain of 2 kilograms in 24 hours, or elevated blood pressure? B is the only one that is specific. So C, the weight gain of 2 kilograms in 24 hours. Daily weight is the most reliable indicator of fluid balance. Okay, so the best indicator of fluid volume excess is gonna be your daily weight. So remember, always get your weight early in the morning. Okay, always get your weight in the mornings for your patient. If you have your patient here and the patient is having crackles on the lungs, which of the, wait, same time, same clothing, yes. If you have a patient that is having crackles on the lungs, we know the patient is in heart failure, okay? Left or right heart failure are you thinking? Crackles on the lungs, left or right? Drop the answer below. Left, left, left. Who's the right? Who was that? Dahizapam. Is that right? Left. Yes. So left things. Think about the lungs. L for lungs. Anita. Okay. Dependent edema. If the patient has dependent edema, if the patient is having dependent edema, left or right? Right. Oops, it's me. Right. Rest of the body. Okay. What are some other signs and symptoms for rest of the body? Right-sided heart failure you can think of. Okay, so left for lungs, everything else is right. Yes, Nick. So just think of it, left-sided L, right-sided R, right. Rest of the body. So, okay, so for right-sided, ascites, yes. Hepatomegaly, JVD, DVT. Or jugular vein distension. Enlarged liver. Okay. Yes, and your pedal edema, things like that. Good. All right. Okie dokie. So we'll go on with, and give me a loop diuretic that you could think of for right is what you can see, left you have to assess. Okay, so oops, it's me says right is what you can see, left you have to assess. Do you review EKG? Anita, no, I'm not. There is a paramedic. I tend to like see him, and I will share his page whenever he's doing his EKGs. Yes, I'm not 100 with EKGs, so I don't pick up that challenge. But he's very good, so I always share it to my story. So whenever I see him, but he's always doing EKGs as a paramedic, so you can always look through the live streams and see if you see his page. But I will try to add it to my story whenever I see him. Okay, so you have this patient. Give me a loop diuretic that you could give to this patient. A loop diuretic that we will give to this patient. Nick says furosemide Lasix, okay. Bumex if they have kidney disease, furosemide, okay. All right, so we've said furosemide about 10 times. Give me something else similar to furosemide. Do we know of any other? Furosemide, bumetamide. Gorse. Are you trying to say torsemide? Oh, so Bambi girl said torsemide. Okay. I see Christopher says HCTZ. What kind of drug is HCTZ? HCTZ, hydrochlorothiazide. Is that a loop diuretic? Is hydrochlorothiazide a loop diuretic? It's a thiazide. No, it's not. It's not a loop diuretic. It's a diuretic, but it's not a loop. Okay. Let's move on to this question. Which task is appropriate for the nurse to delegate to your unlicensed assisted personnel? A, assessing pain after medication administration. B, teaching insulin self-injection. C, monitoring a newly admitted patient. And D, obtaining vital signs on a stable patient. D. Nice. I guess we get that one. Good. So remember, anything you can eat, right? So educate, assess, teach. That's for your nurse. That's your responsibility as an RN. So assessing pain after medication, that's yours. Teaching, that's your responsibility. Monitoring, that's your responsibility. Obtaining vital signs on a stable patient. And remember, look at the keyword here, stable. Then definitely that's something you can delegate to your UAPs. So UAPs can perform routine, non-assessment tasks on your stable patients. Which position is most effective in preventing aspiration during tube feeding? Trendelenburg, B, supine, C, high pholas, D, prone. Which position is most effective in preventing aspiration during tube feeding? C, high pholas position. Okay, nice. Okay. So high Fowler's position or anything that is greater than 45 minimizes the risk of aspiration. When do we use the Trendelenburg position? When do we use the Trendelenburg position? Low blood pressure, yes. Air embolism, Aisha, DVD, DVT pap test, yes. When they're doing those central venous catheter insertion as well, cord prolapse, shock to increase venous return, good. Okay, good. And we know about the supine and the prone position already. Hypovolemia, low blood pressure near syncope. Yes, Christopher. Nice. And remember, guys, go ahead and follow, tap up the screen if you haven't done so as yet, so we can get additional folks over. And if you want the full length of the live streams, they're posted on YouTube at ThinkNursing. Full videos are posted over there for your convenience, okay? All right, let's move on to this one here. You have a pregnant client at 32 weeks who reports sudden vaginal bleeding with no pain. What does the nurse suspect? So you have a 32 weeks patient with sudden vaginal bleeding with no pain. What does the nurse suspect? A, placental abruption, B, preterm labor, C, placenta previa, D, uterine rupture. So vaginal bleeding with no pain. So C, previa, bright red, no blood, no pain, no manual vaginal exams, delivery is from recumbent, I believe. Okay. So it causes painless, bright red bleeding in the third trimester. Abruption is painful. Which of these you think is higher risk? Which of these is higher risk for your patient? Is it placenta abruption or placenta previa? All right, honestly, A and D are close. Uterine rupture. All right, let me narrow it down. Between placenta abruption and placenta previa. So let's go. Bambi girl, let me go back to it. Between placenta abruption and placenta previa, which one of these two are higher risk? Placenta abruption. Cledger, welcome. Shan. Why is it placenta abruption high risk? Why is it higher risk? Why is it abruption higher risk? The mother can go into the DIC and bleed out of everywhere, power tap. Oh, placenta disconnect from the wall. Okay, can lead to. Can cause, okay, so it can cause fetal hypoxia. So no supply, the placenta is separated suddenly, premature separation of the placenta from the uterine wall. Yes, because of that abrupt separation, Bambi. Hemorrhage, yes. Placental insufficiency. It can affect fetal circulation. Fetal demise is another one. disseminated intravascular coagulation, run out of vitamin K and can't clot. Yes, so all of those, you have impairment with gaseous exchange taking place because of that abruption there. So you can have stillbirth happening. So that one is a higher risk. Okay. All right, let's go down to this question here. Which fetal heart rate pattern indicates uteroplacental insufficiency? A, variable decelerations. B, early decelerations. C, accelerations. Or D, late decelerations. So which fetal heart rate patterns indicates uteroplacental insufficiency? A, B, C, or D? D. Oh, veal chop. Okay. D, do lion. So see some of these. There was one young lady the other night. What was her name again? I haven't seen her on the live tonight. She's a midwife. Erica. Processor insufficient. But I've seen some of these acronyms that you guys are using. Okay, so the late decelerations, they're caused by the decreased placental oxygen exchange and are non-reassuring. So just read up on those, okay, for your exam. Read up on those for your exam, because you might find one and two of the words coming in your exam. You won't have like much of your much OB cases or maternity cases, but you find they'll use one and two of these in the exam. So just be, you know, I missed this on one. I got a phone call. Oh, you love maternity? Okay. What is when you hear of accelerations and decelerations though, when I hear this, decelerations and accelerations in labor and delivery, what are they talking about? What accelerations mean? What accelerations mean in labor and delivery? The fetal heart rate. What about the fetal heart rate? Accelerations increase in heart rate when speeding up with contractions. Yeah, so whenever the baby is stressed, or whenever the under stress, contraction during contractions. Yes, and then deceleration is slowing down, right? No movement or less affecting the heart. Okay. Accelerations means contractions. Thank you, Diana. Thank you. Okay. All right, let's go on to this one here. The nurse notes a prolapsed umbilical cord. What is the priority? Remember, as we say, priority, that one thing that you need to do now, okay? So the nurse notes a prolapsed umbilical cord. What is the priority action? A, apply oxygen to the mother. B, place the client in the knee-chest position. C, check cervical dilation. Or D, prepare for oxytocin infusion. So you have a mother here who has prolapsed umbilical cord. What is the priority? I see B. Who's there different? J9 says A, apply oxygen to the mother. All right, so you have a prolapse cord, and we'll put on the oxygen. Let's see what J9 is thinking. So the oxygen is on J9. The prolapse cord is there. What's happening? Just think of it. So you have a mother who has a prolapse umbilical cord, and you apply oxygen. So as I said, don't think of airway breathing circulation just because NCLEX is saying airway breathing circulation. All right, just think of it. You have a mother who is pregnant, and you have a umbilical cord. The cord is there. Never give oxygen without O2 saturation. You have the cord that is prolapse right there. You want to relieve pressure from that that cord for that baby, right? What is the one thing that you need to do? Putting on oxygen is still gonna have pressure there. So you want to go ahead and try to do what? If you place the client in knee chest position, is this gonna help with relieving pressure on that cord? So if you reposition the patient, will that help with it? So you definitely want to put that patient in the knee chest position or the Trendelenburg position to relieve pressure off the cord and restore fetal oxygenation. All right, so even though you have the oxygen, that's not the priority for that patient. To remove presenting part of the cord. Yes. So you want to go ahead and do that. Erin, welcome. Because it separates losing vascularity. Check cervical dilation. This not even make no sense right now. This one, prepare for oxytocin. So just put them in the knee chest to help with relieving pressure. And then that will help with restoring oxygenation. Then you can always go ahead and get that baby out safely. All right, let's go on to this one here. Which finding requires immediate intervention during labor? A, early decelerations, B, variable decelerations, C, late decelerations, and D, fetal heart rate baseline of 140 beats per minute. Which finding requires immediate intervention during labor? As we say, we know that decelerations mean, as you guys said earlier, it's slowed. The heart rate is slowed, okay? So if you're having, which finding requires immediate intervention during labor? So if we know that these are, if decelerations here means slowed heart rate during contractions. So if you have early, then that's good. Variable, you know, you can work with it. Late is gonna be a problem. So we're gonna say late is indicating uteroplacental insufficiency and fetal hypoxia. So fetal heart rate 110, 160. Good. So fetus is becoming hypoxic. Initiate those interventions. So yes, oxygen, prepare for C-section. So just try to understand what that word is, and then you'll be able to kind of make sense, speak sense out of nonsense with the others. Okay. So late decelerations indicate uteroplacental insufficiency and fetal hypoxia. So you want to go ahead, apply your oxygen, prepare for C-section to help with that mother. A client with preeclampsia is receiving magnesium sulfate, which finding indicates toxicity. Blood pressure of 150/96, urine output of 35, absent deep tendon reflexes, headache of, headache. I know. Absent deep tendon reflexes are early sign of magnesium toxicity. The antidote is going to be your calcium gluconate. Let me see if I can find my... Okay. A newborn has a heart rate of 90 beats per minute. What's the rate for your your newborn? What's your rate for your newborn heart rate? What's a normal heart rate? Normal heart rate, 110 to 160 beats per minute. Good. So you notice that this child or this newborn, the heart rate is 90. That's a problem, okay? So not an adult, it's a newborn. So we need to do something. So what is the nurse's first action? A, begin chest compressions. B, provide positive pressure ventilation. C, administer oxygen via mask. Or D, suction the airway. So you have this baby and the heart rate is 90. What are you going to be doing? Let's see, D. Ventilate the baby, Bambi girl. Okay, nice. So let's go on to this question. So airway, breathing, circulation. We have heart rate here of 90. Is there an airway problem? No. Breathing problem? No. Circulation problem? Is there a circulation problem? Answer B. Christian B. Yes. Circulation problem. So what we're going to be doing with this baby? Are we going to do chest compression? We're going to do positive pressure ventilation. Are we going to administer oxygen, or are we going to suction the airway? What do we do for our newborns? So this baby has a heart rate of 90. What do? We do our positive pressure ventilation to help with that. So heart rate less than 100 in a newborn requires positive pressure ventilation per neonatal resuscitation guidelines. So we ventilate them. The first thing, Shan says keyword first. Yes. So what are some things that we can use for, positive pressure ventilation? So what are some things that we use, for positive pressure ventilation? We're going to say back valve mask. Give me some other ways that we apply PPVs to patients. CPAP, good. BiPAP. Let's see, but I think she say, hello, TS Music. CPAP, BiPAP. Your ventilator, yes. Okay. And what exactly are we doing when we say positive pressure ventilation? What is happening with that? What is happening when you hear about positive pressure ventilation? What is happening when you're here? We're going to give this patient positive pressure ventilation. Forcing air into the lungs, keeping the alveoli open. Good. So we use it in, you'll see them use it in like pediatric resuscitation. Which other cases you can think of? Which other cases you can think of using your PPVs in? What are some other cases? We use them in ICU. Bad man fill alveoli with CPAP. And cups. COPD, okay. So COPD. Lung collapse. Your ventilation patient or ventilator. Your overdose patients. Your cardiac arrest patient. ARDS. Atelectasis, your severe asthma. Your heart failure patients. Okay. So let's go down to this one here. Which client is at highest risk for postpartum hemorrhage? Which client is at risk for postpartum hemorrhage? A, primigravida with 8-hour labor. B, client with uterine atony. C, client with episiotomy. Or D, client with hemoglobin of 11 grams deciliters per deciliter. So which client is at highest risk for postpartum hemorrhage? Ziggy, welcome. Congratulations, nurse. So which client is at highest risk for postpartum hemorrhage? The client with uterine atony. Loss of tone means uterus not contracting. Shy 03. I'm sorry to hear. I'm sorry to hear. So the giveaway here, atony, okay. No tone. So loss of tone. So uterine atony is the most common cause of postpartum hemorrhage, okay? Atony is boggy, means not contracting, therefore risk for bleeding. I hemorrhage twice with low hem. I'm sorry to hear, J Hall. Yes, definitely, Zig. So the primigravida with 8-hour labor, that's, out of it. Nothing much there. Client with episiotomy, didn't give much information there. Client with hemoglobin 11, but the client with uterine atony is the one that is a problem. Okay. So after, for example, you have this patient. So after C-section or after delivery, this patient has a uterus that is boggy. How will you go ahead and make sure that this patient is not bleeding out? How can you go ahead as a nurse, or you can encourage a patient to do this one simple thing? What can you tell the patient to do, or what will you be doing to ensure that this patient doesn't bleed out on you? Massage. Yes, you go ahead and massage the fundus, the uterus there. Okay. So you want it to not be boggy, but you want it to be firm, like a little ball. Okay. So you go ahead and massage. Massage, empty the bladder as well. Good. Have them void and massage. Yes. Why emptying the bladder is very important? Why emptying the bladder is very important? Tia Nicole. You say ensure bladder emptying. Why emptying the bladder is important? Ziggy says the pressure. Okay, what about the pressure? What about the pressure? Why emptying the bladder is very important for your patients thereafter? Because the uterus is not in place. Full bladder prevents uterus from contracting. Yes. So you want to make sure that the bladder is not, can make the uterus off place. Yeah, good. Nice. Prevent bladder disc. All right, let's go on to this question here. The nurse is teaching a postpartum client about lochia. Which statement indicates understanding? A. Lochia rubra lasts 6 weeks. B. Clots larger than a quarter are normal. C. Lochia should not gradually change from red to pink to white. D. A foul smell is expected. So which statement indicates understanding about lochia? Lochia rubra lasts 6 weeks. B. Clots larger than a quarter are normal. C. Lochia should gradually change from red to pink to white. And D. A foul smell is expected. C. It usually changes from red to pink to white. Good. Okay. If they have a foul smell, what is that indicating? If there's a foul smell, what is that indicating? If there is a foul smell indicating infection. And are they supposed to be having clots larger than a quarter? Foul smell is not good. Could be endometriosis. Okay. And you don't want them to be having anything that is larger than a quarter. That's not normal. And how long does lochia rubra last for? How long does lochia rubra last for? Four days. So the first part, the first few days, 1 to 4 days. And that's a bright red. Okay. So what are the 3 different stages? What are the 3 stages of the lochia? Go ahead and give me the 3 stages of the lochia. So yeah, we know we have the lochia rubra that lasts for 1 to 4 days. The second stage is which one? Lochia serosa. And how long lochia serosa lasts for? Four to 7 days. Oh, I know 4 to 7. All right, let me pull up something. Lochia. Pull it up. Okay, so lochia rubra, 1 to 3 days. Lochia serosa, 4 to 10 days. And then you have your alba, which is the longest one, which is the see here 10 to 14 days, up to 6 weeks postpartum. 6 weeks, yeah. Okay. So, and as it gets, you know, the longer, it changes color. So it goes from the bright red until it wears off. Rubra 1 to 3, 4 to 7, and then 6 weeks. Yes, Nick, that's what I'm seeing here. 1 to 3, 4 to 10, 10 up to 6 weeks. 10 to 14 days up to 6 weeks postpartum. Lastly, white. Yes. Okay. So the answer here, we say it's gonna be the lochia that usually changes from red to pink. That's normal progression. So rubra, serosa, alba. Anything that has a foul odor indicates infection. You're welcome. Which finding suggests uterine inversion? Which finding suggests uterine inversion? A, boggy uterus. B, severe abdominal pain. C, fundus not palpable. D, increased lochia. So which finding suggests uterine inversion? Okay, so I see AAC, Bambi said C, so laugh for Nick. So the fundus not palpable, okay. So which of them suggests uterine inversion? So when we have the boggy uterus, after B, I mean the uterus is inside out, yeah. So we have the boggy uterus after inversion means it folds down. Yes. Is that what is happening there? We know severe abdominal pain is out, fundus not palpable, increased lochia is out. So is it the boggy uterus or the fundus not palpable? Which one are we saying? The uterine inversion, the fundus cannot be palpable. It's not palpable and it's a medical emergency. All right, so you cannot palpate it. So just remember that after we deliver and the baby, the baby is out, a lot of times the uterus becomes boggy at that time, right? The uterus becomes boggy. So the fundus, the inversion, you can't feel it. It's not palpable. So that's a problem. Subinvolution. Ziggy. Yes. So it's not palpable at that time. So it's a uterine inversion. The fundus cannot be palpated and it is a medical emergency. I think I never fixed these properly. A pregnant client at 36 weeks reports decreased fetal movement. A client at 36 weeks report decreased fetal movement. What should the nurse do first? A, schedule a non-stress test. B, ask the client to drink juice. C, place the client on the left side and count movements. D, notify the provider immediately. So decrease. Why would you go ahead and place the patient on the left side and count the movements? To improve blood flow to placenta, maybe if the baby is hypoxic. Okay. So nature says baby might be sleeping, so ask the client to drink some juice. Is it sleeping, or you want to say probably the baby hypoxic? Not hypoxic, hypoglycemic. Okay, so left side promotes oxygenation, so you want to make sure that they're perfusing well. So Left side positioning improves uteroplacental perfusion and is the first nursing action. So positioning is always one thing that you can try to do, and then from there. Okay, schedule a non-stress test. No, that's a little bit too aggressive. That's a little bit too aggressive. So Mrs. M says lion. What does that stand for, Mrs. M? If they were home, we would say drink juice to feel baby. Okay, okay. Left side position. Left side IV fluid and notify HCP. Okay, so L, left side IV fluid, oxygen, and notify. No, okay, notify HCP. Okay. I think this is where I think probably this is where I messed up. Hold on. Yeah, I think this is where I'm gonna go to my, hold on, I'm gonna turn, after this one, I'm gonna turn the camera and I'm gonna look on the thing here. Which medication is given to prevent preterm labor? A, oxytocin, B, methogen, C, terbutaline, or D, misoprostol. Which medication is given to prevent preterm labor? B, the tocolytic there. Terbutaline. C. And terbutaline. It's a tocolytic that relaxes uterine smooth muscle. That one is used to prevent your preterm labor here. Okay. To buy some time and help mature the lungs. What else can you, what is missing in the baby's lungs? Why they're not, so you have your babies that are premature. What is missing in those premature babies' lungs? What is needed? Surfactant, okay. All right. Your surfactant is missing. And what do we give them when they're born? So the surfactant is needed for the lungs, and what else? So when we don't have surfactant like that, so what else do we give them? We give them bechamethasone. We give them steroids. If preterm, you give them bechamethasone. Dexamethasone as well, Ziggy. Okay. Let me turn this thing here, because I think this is where I'd messed up something. Hold on. And then let me get to, oh yeah, I think it was here. Okay, I think that was it. Okay, okay. So this was a review. Okay. So my eyes them look heavy. Past my bedtime. Anyhow, let me go on to answer that question there. Let's do the severe preeclampsia priority. So let's look at it. So Absent reflexes on magnesium, what would you do? Stop the infusion, and you would go ahead and give your calcium gluconate, right? You have a severe preeclampsia. What's the priority for that patient? You can go ahead and type it. Oh, hold on there. Hold on. So we're going to the severe preeclampsia because the other ones was showing. So that's the one we're doing. Okay. So the severe preeclampsia priority, what would you do for that patient? Maintain blood pressure, prevent seizures, magnesium sulfate, good. Seizure prevention, good. Postpartum hemorrhage shock sign. Give me some signs of shock for your postpartum hemorrhage patient. You can just list them. Low blood pressure, increased heart rate, low blood pressure, cool clammy skin, temperature, hypotension, tachycardia, high heart rate, diaphoresis, nice, good. Loss of blood pressure, bleeding, yes. So tachycardia first and then the blood pressure drops later on, okay? And, oh, okay. So this is where, I think I have, this is a case study. And then I think it has probably about 10 questions and then we will be done, right? Yeah, or probably about 5 questions. So we have here, we have a Gravita 2 Para 1 patient, vaginal delivery. The delivery complication was a shoulder dystocia resolved with Mac-Roberts maneuver. 1 hour postpartum findings. The blood pressure is 92/54. Heart rate is 118. The fundus is firm, midline. Continuous trickling of bright red blood is noted, and the perineum is swollen and painful. Okay. So shoulder dystocia we are having here, that was resolved with a Mac-Roberts maneuver. Probably a laceration, okay. So we have the blood pressure here, 92/58, a little tachycardic, fundus is firm. All right, so the fundus is firm. It's midline. You have continuous trickling of bright red blood. Perineum is swollen and painful. Diagnose the patient, please. Ziggy says hematoma. Okay. Continuous trickling of the blood. Going with laceration too. Okay, nice. Bam Bam Beauty says laceration. Okay. Presence of rubra. Okay. Strawberry. Lady Portia, PPH. Postpartum hemorrhage. PPH. Hi, Jacinth. Welcome. How are you doing? Okay. So let's go on here. Which findings suggest the cause of bleeding? Select all that apply. A, firm uterus, or not A, but 1. Then 2, continuous trickling, large clots, perineal swelling, or boggy fundus. Which findings suggest the cause of bleeding? So as I said, this is The complication, the shoulder dystocia that was resolved with Mac-Roberts maneuver. So the patient is having continuous trickling. So trickling of bright red blood. Which finding suggests the cause of bleeding? Firm uterus, continuous trickling, large clots, perineal swelling, boggy fundus. Remember, treat each answer as a true or false. Firm uterus. If the uterus is firm, is that the cause for bleeding? When it's firm, is it bleeding out? Is it when it's boggy, is it bleeding out? So firm, false. So we're gonna put an X beside it. Continuous trickling, is that the cause for bleeding? You could put a tick beside it. Large clots, you could, large clots, the case study says firm though. So this, yes, this is from the case study. So this is from the case study. So fundus is firm. So the firm uterus. So we're gonna put an X beside it. So the continuous trickling, cause for bleeding. Put a tick, right? The large clots. Is the large clots a cause for bleeding? Yes. Perineal swelling, is that a cause for bleeding? Yes. Boggy fundus. Rose says not necessarily. Okay. The boggy fundus is a cause for swelling. Yes. So the ones that, so perineal swelling would be like a question mark beside it. So it's a little bit tricky here for this question. So let's go on and look at the rationale that they have here. So the firm uterus, continuous trickling, the perineal swelling. This is laceration related to hemorrhage, not uterine atony. So when I was looking at because of this, the uterine fundus, the fundus here is firm. So with postpartum hemorrhage, you're thinking about boggy fundus, atony, bleeding. Yes, Kinjit. Boggy fundus, atony, bleeding. So with this fundus that is firm, you're not thinking about any excessive bleeding. So you're not thinking about like your PPH there. So even though the patient is tachycardic and hypotensive, you're not thinking about, your PPH here for this patient. So the continuous trickling can be because of the fact that they probably had a laceration. All right, it can be because of the laceration during this maneuver that happened. So which finding suggests the cause of the bleeding? It's not going to be because of the firm uterus here. I'm thinking the continuous trickle. Oh. Let's look at the answer here. The laceration related hemorrhage, not uterine atony. Firm uterus and ongoing bleeding, trauma. Okay. Shoulder dystocia increases the risk for vaginal or cervical tears. Okay, so firm uterus and ongoing bleeding, probably because of a trauma. Okay, I understand what they're saying. So if there is a trickling, it's not from the PPH, it's not from your postpartum hemorrhage because you have your uterus that is not boggy. It's not boggy. So it's not, the firm uterus makes me confused. So you can have your firm uterus, but if, so for example, you're still having the bleeding, if you're having the bleeding, they probably have accidentally lacerated the uterus. It's not because of the the fact that the patient is from the laceration, yes, or tear in the cervical wall. Exactly, shy. So you can accidentally lacerate the uterus. So it might be, it's trickling. It's not like, say, why firm? Because it's not like a massive laceration. It's not like you literally chop the uterus. So even though it's boggy because you just had the baby. Or the mother just had a baby. So it's going to be boggy. If it was boggy, heavy bleeding, maybe retained placenta, exactly, then you'll be thinking about like your postpartum hemorrhage with the heavy bleeding. But if it is firm and you're still having trickling of blood, it can be because of an accidental laceration of the uterus, the uterine wall. Because it's not excessive, then that's the difference here. So you can have a firm uterus and you can have accidental laceration or a tear. It's not excessive bleeding. Yes. So it's not a large laceration. It's just a small tear that, is just trickling blood. So it's just for them to go ahead and just apply some pressure or something there to help with stopping that bleed. Yeah, no problem. Hold on. Okay. So this is the question. So the question is, a shoulder dystocia resolved with Mac-Roberts maneuver. So, and then you have blood pressure. So 1 hour postpartum findings. The blood pressure 92/54, heart rate 118. Fundus is firm. It's midline. So the baby, so everything is okay in terms of, after delivery. So the fundus is back to where it's supposed to be at 1 hour time, postpartum. There is still continuous trickling of bright red blood. Where is that blood coming from? So, and then their perineum is also swollen and painful. Remember, this was a shoulder dystocia case. All right, where they had to do this maneuver. So nothing more than when they're doing the maneuver, they accidentally lacerated. How does a firm fundus cause bleeding? Because you accidentally cut it. You accidentally cut it. So because of what they were doing, you accidentally cut it. The 4 T's, tone, tissue trauma, and thrombin. Because okay. Okay. So let's go back through so which findings suggest the cause of the bleeding? Select all that apply. The answer is going to be the firm uterus. So the firm uterus is the cause of the bleeding because of possibly the laceration, the continuous trickling, large clots, perineal swelling. It never made mention of a boggy fundus because this fundus here is firm, okay? So the firm uterus, the continuous trickling, and the perineal swelling. This is laceration-related hemorrhage. It's not related, it's not a postpartum hemorrhage like what you normally have after, if you haven't, massaged the uterus properly after delivery. That's totally different from this kind of hemorrhage here. Don't mention about any. So yes, it's 1, 2, and 3. Okay. So the firm uterus and ongoing bleeding is trauma. Shoulder dystocia increases the risk for vaginal and cervical tears. Okay, nice, Dorcas. I hope that clears it up for you, Carousel. This is related to buggy and not firm, so I'm confused. So Carousel is still confused. Try to just think about it, read on it a little bit more, and try to understand it, Carousel. So even though it's firm, the uterus is firm, you can still have bleeding from it. You can still have a little bit of a bleeding if you accidentally use a little razor and cut your uterus. If it was a boggy uterus, it would be a total different case. But this one is a firm uterus, but it's bleeding. So why, if the uterus is still intact, why is it leaking? Let's just think of it like that. Something must have happened, right? And we know that they were there trying to get this baby out using different devices that maneuver there. So something happened during the procedure. So you just have to think that they accidentally cut something. Okay. All right. So for this patient, what is the priority nursing action? A, massage the fundus. B, administer oxytocin. C, apply ice and notify the provider. Or D, insert a Foley catheter. So what is the nursing priority here for this patient? So we know it's a laceration-related hemorrhage. It's not a postpartum hemorrhage. What is the priority action here? Are we going to massage the fundus? The fundus is already firm. Do you still want to massage the fundus? Why do we massage a fundus? Because we want to get it firm. This fundus is already firm, but it's still leaking. Do we still need to go ahead and massage it? No. Administer oxytocin. Apply the ice. Insert the Foley. You want to go ahead and give the ice. Uterotonics and fundal massage do not fix lacerations. This patient needs a repair of the tear. Okay. So is it a perineal swelling? Yeah, the patient is having some perineal swelling there. Perineal swelling, trickling of blood, and the uterus is firm. So laceration related to a hemorrhage. So we're gonna go ahead and apply the ice and notify the provider, because that patient needs to go back to the OR so they can figure out where that tear is and repair it. Thank you for that gift, Jacine. Sydney. All right. As I say, you can get the full length of the live streams on YouTube at ThinkNursing. One word, just in case you show up late. Sydney Smith. So C, to help with perineum for swelling and notify HCP because of trickling of blood. Exactly, Shy. Okay, let's go on to these two. So you have a patient here, two patients. Patient A is 36 weeks, painless bright red bleeding, soft non-tender uterus. The fetal heart rate is reassuring. So 36 weeks, painless bright red bleeding. What pops out to you? Painless bright red bleeding. What's that? Placenta previa. High risk or low risk? Just went over this. Yes, we did. Placenta previa. Is this a high risk patient or a low risk patient? Well, we know it's a high risk, but between placenta previa and abruptio, which one is it? Is it high risk or low risk? Between placenta previa and placenta abruptio or abruption, which one is a high risk? Or is this one a low risk? So it's a low risk. Okay, good. So 36 weeks, painless bright red bleeding, soft, non-tender uterus, fetal heart rate reassuring. Abruptio is high risk. Yes, nice. Then you have a patient here, B, 34 weeks, painful dark bleeding, rigid tender uterus, and late decelerations. So the 34 weeks here, painful dark bleeding, what's that one? Abruption. So Ziggy says late insufficient placenta. Okay. Okay, so this one is the problem patient. Right, this one is the problem patient. Placenta abruption, get them to the OR. Good. So let's tell the difference. So we say here placenta previa. You said it earlier. Placenta previa is the rose. So the placenta previa is no pain. All right, so let's go through placenta previa. Let's go through placenta previa, then we'll do abruption. So we say painless. So painless, the bleeding color for your placenta previa. What's the bleeding color for placenta previa? Bright red. Okay, the uterine tone. What's the tone? Is it soft? Is it rigid? Uterine tone for your placenta previa. Is it soft, rigid? Okay, boggy, nice. Yes, Nina, welcome. And then the fetal risk. Is it high or low? Is the fetal risk high or low for your placenta previa? Okay. It's minimal low. And then for your placenta, good. And then your placenta abruption, we say it's painful. The bleeding color is dark. The uterine tone, we said up there, is rigid. And then the fetal risk is very, very high. There you have it there. Good. Firm uterine and fetal risk. Oops, it's me. Ziggy says hi, dark red. Okay, good. So placenta previa, painless, bright red, soft uterine, decreased fetal risk initially for your placenta previa. Abruption is painful, dark bleeding, rigid uterus, and high fetal risk. Okay. Remember, never perform vaginal exams with unexplained bleeding. And this is something that NCLEX loves. So always know why the patient is having a vaginal bleeding, because it can cause perforation. Which provider order should the nurse question for patient A? So patient A is the 36 weeks, painless, bright red bleeding, soft, non-tender uterus, fetal heart rate reassuring. So which order, let me take my time because I don't want to show the answer. So which order should the nurse question for patient A? The continuous fetal monitoring, prepare for C-section, perform vaginal exam, or type and cross match. C, nice. Okay, so perform vaginal exam. As we said, never Perform vaginal exams with unexplained bleeding. Fetal monitoring is something that you definitely want to do continuously. No, Christopher, you're not going to question that one. You want to make sure you get that one going. So you always want to get your fetal monitoring going, okay? Prepare for a C-section. You're not going to question that. And type and cross match, you want to get that going. So everything is good except C, performing this vaginal exam. Vaginal exams can cause catastrophic hemorrhage in your placenta previa. And so you want to stay away from that. Immediately postpartum, you have sudden onset of dyspnea, cyanosis, hypotension, seizure activity, DIC labs later, abnormal. Which findings support amniotic fluid embolism? Select all that apply. Sudden respiratory distress, hypotension, seizures, gradual postpartum bleeding, and DIC. Which findings support amniotic fluid embolism? And just like any other embolism, you know, medical embolism, this is a maternity or obstetric emergency. So which findings support amniotic fluid embolism? See 1, 2, 5, B, C, D. So sudden respiratory distress, hypotension, seizures, gradual postpartum bleeding, or DIC. So select all that apply. And remember, for your NCLEX, only choose whatever you are confident with in your answer. All right. Whatever you're confident with, you just go with it. You lose points for the incorrect answer. So if you only know one, stick with your one. All right. So sudden respiratory distress, hypotension, seizures, DIC. So amniotic fluid embolism is sudden, catastrophic, and unpredictable. So treat with supportive care. So your sudden respiratory distress, hypotension, seizure, who had said that again? And this one, the gradual postpartum bleeding, that is not, you know, when you think about, just think of embolism like an ear embolism. Just think about that, and then from there you can choose your answer. But the gradual postpartum bleeding, yeah, you can take that one out. Alright, with the DIC, seizures, hypotension, sudden respiratory distress, can think about those. Not sure about 5, can cause massive vasodilation. What is the nurse's immediate action? What is the nurse's immediate action? Administer oxytocin, call rapid response, place patient in Trendelenburg position, or D, assess for lochia. So you have this patient, what is gonna be your immediate action? B, call rapid response. Administer oxytocin, place patient in Trendelenburg position, or assess lochia. I worked in specialty imaging for 21 years and never scanned a pregnant patient. I am deficient in. Oh Lord, Christopher, you're funny. So what is the nurse's best response here? You want to go ahead and activate your rapid response. As I said, this is an emergency, so you want to go ahead and call for that. So this is a maternal collapse emergency, so go ahead and activate your code for that patient. The others just don't make any sense for this patient. All right, I think I have 2 more slides and then I'm done. I'm sleepy. A laboring patient is receiving oxytocin. Which findings requires the nurse to stop the infusion? What do we know about oxytocin? What do we know about oxytocin? It's a stimulant, contracts the induced labor. What gland is responsible for oxytocin? What gland is responsible for that one? Contracts the glands. Helps in postpartum hemorrhage, okay. What gland is responsible for producing oxytocin? Anterior pituitary gland, also ADH in high dose. Okay, yes, Ziggy. Okay. So, which finding requires the nurse to stop the infusion? Select all that apply. Contractions lasting 110 seconds, fetal heart rate late, decelerations, resting tone elevated, cervix dilating rapidly, or minimal variability. So, which finding requires the nurse to stop the infusion? Fetal heart rate decelerations, okay. Prostaglandins ABD, late decelerations, okay. Sherry says 2, fetal, okay. Contractions lasting 110. All right, so I see a mixture of those answers, 1, 2, 4. See, one person says C, resting tone elevated. Cause I'm on TikTok and on YouTube, Jacinth. Okay, so contractions lasting 110 seconds, late decelerations, resting tone elevated, minimal variability. So uterine tachysystole, decreased placental perfusion leading to fetal hypoxia. Okay. So which finding requires the nurse to stop the infusion? Contractions lasting 110 seconds. The fetal heart rate late, decelerations. The resting tone elevated. And the minimal variability. And that's because you have uterine tachysystole decreases the placental perfusion leading to fetal hypoxia. This patient will need C-section. Mardisha, welcome, welcome. And remember to go ahead and follow the page. I do live stream on Tuesdays and Thursdays at 7 p.m. Central Standard Time. I'll pop up at 7 p.m. as well. I'll pop up at 7 p.m. as well on other days. And then from there, we'll try to do a live stream if possible, okay? Let's look at this one here. Which patient should the nurse see first here? You have a 38-week patient with a blood pressure of 148. Let me move this. 148 over 92. A postpartum patient with respiratory rate of 26 and chest pain. Laboring patient at 8 centimeters screaming in pain, or gestational diabetic patient with a glucose of 72. Which patient will you see first? You're going to try to keep the person that is screaming very loudly down. Are you going to see that one first? So which patient are you going to see first? All right, so I see B's, chest pain. All right, so chest pain, Jacinton Whitey, Christopher, chest pain. Okay, the postpartum patient with respiratory rate of 26 and chest pain. And C, okay, so C is expected according to Z. Laboring patient at 8 centimeters screaming in pain. Okay, so Roth B says she would go and see C first. Why did C first? Because C is making a lot of noise. All right, don't get distracted with the screaming patient. Loud doesn't mean that they are the most, you know, urgent or the emergency in the room. So the patient, who should you see first? Airway, breathing, circulation. Go throughout your, go throughout your 4 patients you have there and then decide on who you'll see. So A, 38-week patient with a blood pressure 148/92. We know 38-week pregnant. Yes, blood pressure is elevated. Put a little question mark, we can circle and come back. Okay. Postpartum patient with respiratory rate of 26 and chest pain. Postpartum, respiratory rate 26. Why? Patient is having chest pain. We're gonna put a little tick beside that one. Let's go down to laboring patient at 8 centimeters screaming in pain. Yeah, you're in pain, ma'am. So we can circle and come back. Okay. And then we have the gestational diabetic patient here with glucose of 72. She's fine, right? So let's go back up to not the screaming patient, but that postpartum patient there and your 38-week patient with a blood pressure. Between your 38-week week pregnant patient and your postpartum patient with the respiratory rate of 26 and chest pain and the blood pressure that is 148, who is at highest risk? Airway, breathing, circulation. You're going to go with your respiratory rate 26 and the chest pain, okay? You will go ahead and do your B. So the postpartum patient with a respiratory rate of 26 and the chest pain is possible PE. Patient is chest pain and tachypneic postpartum, possible PE. So that's the one you will see first. So given the fact that this patient is postpartum and having chest pain, what kind of PE are you thinking about? Let's just say, if you're thinking about an embolism for this patient, if you were here a few minutes ago, what kind of embolism are we probably thinking about? Let's just see. We already say PE. All right. What other risk for this patient is there? Air, amniotic fluid embolism. Yes, nice, Ziggy and Carousel. You're good, Nick. You're good. But I'm just saying, see that we're still under, like, you know, your obstetric. So this patient would be at risk for your amniotic fluid embolism. So the respiratory rate of 26, chest pain. So this would be a priority patient. Then you could go on to seeing your 38-week, your 38-week pregnant patient here with a blood pressure. Then you can always go ahead and address this is your diabetic patient. Could go ahead and give this one, well, this is what, 72. I'll probably go out to the screaming patient here. Find out if everything is going on. Sometimes I just need a little bit of a, but then she's 8 centimeters, so I would go and see her. And then probably come back and circle this diabetic patient. But B would be the patient that I would see. Okay. Oh, we're almost done. Oh, I think we're almost done, right? Oh yeah, I'm almost done. All right, so these are just some little pointers that we have. So firm uterus and bleeding, you think about lacerated. It's a laceration there. All right, firm uterus and bleeding, thinking about a laceration. Painless bleeding, previa. And when you think about placenta previa, placenta previous, meaning the placenta come down first, previous. So you have painless bleeding. Painful bleeding, abruption, it abruptly suddenly tear off. Just think of something ripping off suddenly. Abrupt, it's painful. That's how it's like dark blood. All right. And then you have tachysystole. When you have those patients, you stop your oxytocin. When you have your patient on your oxytocin, you stop it. And then always remember, mom, you resuscitate mom first and then baby after. And we always say in nursing school, you treat mom and then baby will survive. So mommy first and then baby after. Whatever you do for mom happens to baby. All right. When you're trying to resuscitate. And yeah, that's the end of class. Oh my word. That was it. I am sleepy. My little boy get extra today. Him get extra with TV time. Hi. You like the interaction? You must see over TikTok. People them can type. You see them type fast. Yes. They type so fast on TikTok. Them type faster than me. I wish I had some of these folks to type my notes. He was supposed to be in bed, by 8 o'clock. 8 o'clock is his bedtime. You don't do TikTok? TikTok is fun. It's fun. You would like it. Yeah. Thank you so much for the interaction. I am amazed. I retain so much. I'm 54 and ready to find an accelerated school. Okay, nice. Congratulations. Just make sure you subscribe to the page. Thank you, guys. Thank you. Okay, thank you, Dorcas. Thank you for joining in. And as I say, if you come on late for the live, you can always feel free to subscribe to my YouTube page at ThinkNursing and get the full videos over there and all the other live streams that I've done so far. Okay, thank you for doing that. They're all posted over there. You're welcome, Kai. Yes, go ahead and do that, and then feel free to inbox me if you have any questions. I'll try to check my mail, as much as quick as I possibly can. And Ziggy, you're gonna do well. All right, you're gonna do well. So please come more with case study. Okay, no problem, Amor. I'll try to do that. Carousel, thank you so much for tuning in. Okay. You're only seeing Christopher chat. Yeah, most of the time the folks come onto the YT, they don't really talk that much, you know. I'm just saying. I don't know why. They don't really talk that much on YT. I think they're shy. It's ThinkNursing. It's the same as the handle here on TikTok. On TikTok. All questions on education basis. Oh, all questions on education. I don't know. I don't understand that, Ziggy. Sorry. Type again. Are there specific nights of the week? So on Tuesdays and Thursdays for now, I do on at 7 p.m. Central Standard Time. So that's the time I do show up on Tuesdays and Thursdays at 7 p.m. Central Standard Time. Sometimes I'll come on, you know, other days, but it's not promised because I do a lot of traveling and then I'm starting a new job and it's gonna be a bit of a, you know, it's gonna be a bit. So I'm only sticking to the Tuesdays and Thursdays. If I finish working, completing my notes on time, then I'll jump on for the live. Thank you, Rubrio. Thank you. I'm happy you do. Remember to go ahead and subscribe. Subscribe to the page. Are you coming to Texas? Make sure you I don't know. Inbox me. Oh, me not even know how to inbox you. You have my number, Jasin? User 8700. I like your teaching. Thank you. Thank you. Yeah, I like when you have this kind of interaction. When you have this kind of interaction, you tend to remember certain things. That's just how you know, when I was in nursing school, this is how we used to interact in our little group. And I used to enjoy it. I can't sit down by myself and study. It was boring. I'm not lie. It was boring. So when I was doing my master's, it was hard. I'm not lie. It was hard. So I say, when I started my YouTube page, this was one thing I wanted to do. Have little study sessions so persons who wanted to study can come over and just chit chat. Yeah. 7 p.m. Central Standard Time on Tuesdays and Thursdays. But you can check out the page at 7 p.m. some, you know, on the other days and see if I'm doing any study session. I thought I'm right today because of what? Yeah, you were answering questions good. Sometimes, you know, we get a little bit anxious when we're going to the exam. That's all. I mean, all questions basically comes to me on education. Oh, okay, okay. I would like to know if there is another. Yes, there is going to be another class on Tuesday. And probably, yeah, there's going to be another class on Tuesday. Probably Monday. I'm not working on Monday because Monday is holiday. I'm not working on Monday, so I'll probably do a pop-up on Monday. Okay, I'm happy that you're here, Cherise. I'm happy that you're here. Yeah, I never needed to know LND. Okay. I don't know much about LND. I just know like the basic, you know, information for LND. I used to read H&P and the person once a daily. Okay. But Jacinth, are you moving to Texas or are you just coming here short, you know, for a short trip? I am in Texas. I'm in Texas, Dorcas. I am in Texas. And it's nice. It's nice here. It doesn't feel like it's winter now. I think next week they say it's going to be about 20 degrees or something. But it has been pretty nice in the winter this year. So, not complaining. Oh, you're not moving here permanently? Oh, you just a pass through. Okay. Oh, where are you, Dorcas? Where are you? Yeah, Texas is nice. And especially if you're in one of those tropical places, this is pretty okay. It's pretty okay. Oh, you're in Michigan? Oh, I've never been to Michigan. I think I've passed by there, you know, on the side. It's nice down here. It's nice. You don't like the snow? Me neither. I was in Maine for a while, probably like 2 years, and me never like it. I never like one bit about nothing about it. I like the snow like when I'm inside looking out, but that was it. If I was supposed to stay indoors, that would have been okay, but But then, Justin, it depends on which side of Texas you're going, because Texas is huge. It's very huge. Because the last time I checked, it's a couple of hours driving from south to north and from east to west. Let's look up the amount of hours. So driving time from north to south, Texas. It's a couple hours. 16 to 18 hours. So if you're going Dallas to Houston, from where I'm at to Houston, is 4 hours. So San Antonio is roughly 6 hours. Oh, you work in Michigan before? So it's a bit of a drive. So from Dallas, the southern tip, all the way up, it's like 17 to 18 hours. So Texas is not a small place. It's huge. I remember I was doing a road trip to I was going to, where was I going? I was going to the Grand Canyon. I may I tell you, say I was driving. I feel like I do all day. So I say, all right, now time to stop. After I drive 8 hours, and I decided I'm gonna go and find somewhere to stay. Me only hear the GPS tell me so I'm still in Texas. Nothing but me so. I said still in Texas? 8 hours and I'm still in Texas. I'm like, no. So it is huge. It is huge. 8 hours driving still in Texas. Yeah, leave my house. I'm going to Grand Canyon, and only to find out that 8 hours later I am still in Texas. It makes driving hard. Or the snow. What kind of car you have? What kind of car you have? I had a Subaru. I never had any problems with it. I've always loved Subaru. Subaru was my my vehicle. Never had any issues with the snow. So my 1993 grad of Wheeling is suit. Nuclear medicine being out of the field since 2011. I was talking to a friend about applying to nursing school, and then your page came up after. Well, hang around, and you might just, find the love for nursing. So just continue to hang around, and you might just find out that you want to just go in and just do something different in nursing. You might not want to do bedside nursing, but there might be something that aligns with nuclear medicine. Who knows? Yeah. So that's just it. All right, guys, my eyes them tired. I am gonna go to my bed. Yeah, I'm gonna go to my bed. I have another meeting tomorrow with the new company, because their system wasn't working today for me to sign up everything. Can you please talk about the new change in NCLEX from April this year? Dorcas, I'm gonna tell you, I'm gonna be honest with you. I'm gonna be honest, very, very honest. Sir Ellis, good evening. How are you doing? No, not sleeping yet. I'm gonna be honest with you. I am not 100% up to date with all the changes so far with NCLEX. I am not 100% up to date with everything. I know you have some pages that are out there that is like on top of things with NCLEX. I talk about everything on my page, like every single thing. I'm not really like say 100% focused on just NCLEX. So I would have to look up that information and then get back to you. But that's just my honest, my truth about the NCLEX right now. I'm not 100% on top of things as it relates to like, what they're going to be doing in terms of the exam. And yeah, no. I'm just here to study and have you guys study with me and keep you company, teach and all of that. How does that sound? And I'll try to answer one and two things. Yeah, but I will try when I read certain things and whatever I get from that, I will try to just post it on my page. But as I say, as it relates to certain things, I don't have all the up-to-date information because it's not like I am just like strictly about NCLEX itself. And so I am not just sitting down looking for the NCLEX this and NCLEX that. So yeah, that's just it. My goal is to just come here and try to just study, make sure you get the content, and then you apply it to your NCLEX. If you're in the Caribbean, you should be able to apply that information to the RENR exam that we do in the Caribbean. And if you're in nursing school, you should be able to be thinking, learning. When you get out, it's supposed to be helping you in the working world. All right, so it's not only geared towards the NCLEX itself. So that's just it. But I will do a little bit more research on that and try to answer your question at the next class. All right, Dorcas. Gone. Hello, how are you doing? So how was your day, Ellis? How was your day? How was work? The physician friend I was talking to tonight about my trigeminal neuralgia was just in Jamaica. Oh, I bet he or she had a wonderful time. I know they had a wonderful time. Can't wait to go down there. A beautiful woman with a beautiful heart. Thank you for the studies. It was really worth it. Oh, Kamara, I'm so happy. I'm so happy that you find the class, wonderful, wonderful. You're welcome. Yeah, can't wait to go down. Can't wait to go back home. How to auscultate? How to auscultate? You have a good stethoscope? Make sure you have a good stethoscope. All right. And what else can I say? Make sure you clean out your ears good. So you can listen. And what else can I say on auscultating? Have you been watching any YouTube videos? Yes, you have to make sure you watch your YouTube videos and know your landmarks. Know what you're listening for. You have to actually know what sounds you're listening for. So listen to YouTube videos to hear the different sounds, what is normal and what is abnormal. And then you use individuals in your home as guinea pigs. And then from there, you try to hear those sounds, the normal sounds. All right, so if you have any children home, you try to use those individuals as your pediatric clients to hear the different heart sounds, bowel sounds, and it's the same thing for your adults. And from there, that should help you with auscultating. So if you're auscultating your bowel sounds, you use the same guideline for your abdomen, and if you're auscultate your lung sounds, your heart sounds, it's the same thing. All right. Yes, we're Jamaican, Jacinth. I hope that helps with answering your question there, or your gun. Yeah, but I use a lot of videos to help with my health assessment, and then I use individuals around as my guinea pig. And then as soon as I get on the floor, yeah man, my stethoscope up and running. And even when I cannot hear, I am there trying to listen. Trying my best to listen. And once you start hearing that first hard sound, that first vowel sound, that long sound, yes, once you're able to identify the normal sound, then you'll be able to identify the abnormal. All right, yes, I am gonna go to my bed. Any more questions? Any more questions before I go? No. All right, well, it was nice having you guys here with me tonight. I will see you in another live. Remember to go ahead and follow. You can also subscribe to the YouTube page at ThinkNursing, where the live streams are posted, so you can get the videos over there. All right, Jacinth, enjoy your night as well. Dorcas, thank you for sharing up the live. Enjoy your night. And I will see you guys. The biggest contradiction in medicine is the patient's refusal. Yeah, patient has a right to refuse. They have a right to refuse. But, you know, we just have to document. Just have to document. That's all we can do. Document that they refuse. You educate them and document, and that's just it. You can't force anybody to do something that they don't want. So once you educate them and you clearly document what you educate on, the risk, the benefits, you just have to document it to protect yourself. All right, Christopher, make sure you come back to my live stream. Thank you so much for making the chat alive. Jacinth, thank you for making the chat alive, as well as Jose. Yes, all of you guys who participated in the chat, and you know, the ones that are in the back, the quiet ones, what do you call it, the silent watchers. I see you. Yeah, I see you. I appreciate you taking the time out to be here. All right, I do. So I am gonna go now and get my son off the TV because him feel like it's TV night. Yeah, his alarm was supposed to go off, but he never wanted to keep it on tonight. So I was like, all right, you know what? No problem. It's almost the end of the week, so I'll just give him the extra hour. So I'm gonna get him to his bed now. All right, so enjoy your night now, guys. Bye. Took a girl on a first date and she ran into an ex of hers. They literally sat and talked for a whole 10 minutes while we were at dinner. God chosen one. Uh-oh. Well, God chosen one. Well, you sat and wait, so you're the chosen one. Yeah? You sit down and wait for the whole 10 minutes. You should have taken her and just go about your business. I tell her, I said, no, it will never happen. Not right now. It's not right now, mademoiselle. Another time. So what happened? The red flag, Jacinth. Him open up my eyes now. Let me just ask the other question. So what happened? Was there a second date or not? Was there a second date or she ran back to her ex? I ordered the most expensive steak and left them both with the bill. Okay. You're the chosen one. Yeah. That no sound bad. A bedtime. No second date. All right. Well, I hope you find, I hope you find the right one. Hope you find the right one. Well, enjoy your night, All right. Enjoy your night. Jacinth and all the other folks on the live here. Thank you so much for tuning in. God bless you too. All right. Bye-bye. Or later, Jacinth. Your problem.